going to talk about sensory experiences in the NICU, and we'll hopefully finish by noon. It'll be a little shorter so that we don't hold you up from lunch. So objectives of this talk. So I'm going to briefly review the scope of neurodevelopmental impairments in children born preterm, mostly focus on preterm, but in general. And then understand the potential positive and negative impacts of sensory experiences on patients in the NICU, and review the current evidence for sensory interventions in the NICU environment. And this will all make more sense once I get into the talk. So just to kind of set the stage for the scope of the problem of preterm birth. So the rate of preterm birth is about 11% worldwide. It varies from 4 to 18% depending on where you look, and it is unfortunately increasing. And issues related to preterm birth are the leading cause of childhood mortality in children under the age of 5. About 1 million babies die every year from complications of preterm birth. And as we're getting more and more adept at keeping children alive with our medical interventions, you can imagine there is significant morbidity that also results apart from the mortality. So we know that preterm babies, as I alluded to in my last talk, are at increased risk of structural brain injury, so interventricular hemorrhage, periventricular leukomalacia, cerebellar hemorrhage. But we also know that they are at increased risk even in the absence of these structural brain injuries. So, and even if they don't have a complicated medical course, again, going back to how much brain development happens when these babies are in the NICU in an environment that is not conducive to the brain developing as it should in the uterus. It's a very different environment. And we know that there is increased risk of neurodevelopmental impairment with the following: younger gestational age of birth, it's pretty proportional to that, lower birth weight, lack of prenatal magnesium or steroids, which we know are neuroprotective, lower maternal education and lower socioeconomic status, unfortunately, and lower brain volume. So I can't get away from talking about this too many times today, the development that happens throughout the third trimester, what would be the third trimester when babies are in the NICU. And so this is the time of peak brain growth, synaptogenesis, development of receptor populations. So the environment in which this happens, you can imagine, even, apart from what medically is going on with the baby or if they have any structural brain injuries, is really important in terms of shaping the development of the brain. My favorite picture again, I'll skip over this since I already went over it in depth in my neuroimaging talk, but just to say the amount of brain maturity and development that's happening when these babies are in the NICU. So we also can look at not just structurally the differences in preterm brains, but also functionally. Well, this is actually looking at volume. So you can see everything that is in red or orange is where preterm brains are found to have lower volume. And these are in babies that don't have, major structural injury. There are areas in the preterm brain that we know have a lower volume in general than term controls. And then conversely, there's a couple of areas that actually have increased volume. But the point is that there are differences in structure, even in the absence of major injuries. And then we also know that there are differences in function in these babies because the brain, it's mapping itself. So during the 29 to 32 weeks, so this just basically shows you, I'm not going to get into the nitty gritty of this, but it shows you the different, thank you, Dr. Perry. This is basically an fMRI that lights up with functional, like, neuronal firing. So the differences in the earlier preterm baby, and then this is a term equivalent, and term control. So these are the preterm babies when they reach term equivalent age, the second to the last one, and then the term control is that last. So one point I wanted to make is the functional connectivity between the hemispheres. So you can see that happening as the baby gets older, right? And then the other point is that the term equivalents and the term controls are different. So the function is different. I won't belabor that point, but where this brain is developing matters. And we know, like I mentioned, that these impairments are inversely related to gestational age and weight. And this is displayed, on the image to the right. So this is gestational age in weeks, and this is the developmental quotient. So it's a pretty linear relationship in terms of earlier you're born, the more likely you are to have more neurodevelopmental impairment. And then these are the stats for kind of the major comorbidities, neurologic comorbidities associated with prematurity. So hearing loss, cerebral palsy, epilepsy, not insignificant, and more risk. I mean, as many as a quarter of babies born under a kilogram. But there's also really high prevalence of kind of, so-called lower severity dysfunction. So that includes low average IQ, learning disabilities, ADHD, behavioral problems. As many as 50 to 70% of very low birth weight infants have these kind of lower severity issues. So it is pretty profound, the impact that premature birth has on these babies in terms of their neurodevelopment. So all of that paints a great picture, but what can we change? Because you can't change the gestational age of the baby once they're out. So something that we do have some control over is their environment. So we know that compared to the intrauterine environment, babies in the NICU experience excess of certain sensory stimuli and deficiency of other stimuli that are beneficial. So excess pain and stress, hormonal disruption, light, noise, infection or inflammation, and potentially hypoxia or ischemia, depending on their medical comorbidities. Deficient sleep, responsive touch, parental presence, social interactions, language exposure, nutrition. So all of these are really important. So I'm going to go through each one quickly. So touch has been studied in multiple different ways. So people have looked at passive movement and kinesthetic kind of guided position changes, gentle human touch, especially in very preterm or medically unstable and patients who can't really be held safely, caressing or stroking, massage. There's a lot of so I put some stats up there just in some of the papers that I reviewed. There's improved weight gain, digestion, development, decreased pain, length of stay, stress. So a lot of positive impacts just from human touch, because these babies, a lot of times are hooked up to machines and aren't able to experience that normally. And part of the touch is skin to skin. So skin to skin has been shown pretty much across the board to decrease overall mortality, severity of, instance of severe infection or sepsis, and length of stay. And so they even have studied this in multiple different countries. So I think on the top, sorry, I keep trying to click the laser and hit forward. So this was in India and I think a couple of different countries in Africa that they kind of did a proof of concept of, okay, put the baby immediately on mom's belly, even if they're very low birth weight, and it actually improved survival. We have long-term outcomes that we know that executive function seems to be better sleep, emotional regulation. So really, really important stuff. And so because of all of this research that's been done, for the past about year, we have done a initiative at Norton Children's Hospital to try to get babies out of their incubators safely and in a timely manner in order for parents to hold them. And so this is an example of what Dr. Singh likes to call a cuddle huddle. So we have instituted this to kind of get all parties involved in the decision making. Is it medically safe? What barriers are there in terms of having parents hold baby? Because not only is it good for the parents, but we know that it's also very good for the baby and their health. And so these are just some examples of some of the successes with the cuddle huddle. And so we have been tracking data, and it you can see that our time to hold has really improved, which is really exciting. So it started at, or, peaked at, and so these are in days. So it peaked in about a year ago at 25 days. So it was an average of 25 days before these parents could hold their babies. And now we are down to about 2 days. So that's a big win. All right, so pain. Multiple studies have been done to kind of get a gauge of how much pain are these babies exposed to. And, a lot of it is medically necessary, but it is exposure to pain nonetheless. So on average, babies in the NICU tend to be exposed to 7 to 17 painful procedures every day. And so you can imagine this has an impact on how your brain wires itself as it's developing. And so we have actually discovered that the thalamus, the sensory regions of the thalamus, are lower volume in babies who are exposed to more pain. And so why does that matter? Well, thalamic growth has been associated with cognitive and motor outcomes at 3 years corrected age. So it's just another element of the exposures that these babies are undergoing in the ultimate neurodevelopmental outcomes. So, I'm not saying to snow all the babies with medicines as you do the painful procedures, because those in and of themselves, I'm not going to get into that in this talk because it's a whole nother talk in and of itself, but those have also been found to have their own neurodevelopmental consequences and potentially negative effects. But what has been looked at is doing skin to skin as an analgesic. So these are examples of grimace and cry. So babies exhibit less crying, less grimacing, indicators that they are stressed or in pain when a parent is holding them during a painful procedure. So some countries in Europe, like I think Sweden, some of the researchers presented their work at the Newborn Brain Society conference, which is an international conference, so a lot of the presenters are from Europe, and they had pictures of how they intubate babies while on parents and things like that. So that's kind of like the extreme end, but so a lot of this work comes out of, how can we provide analgesia and decrease pain without providing, just doing more medication. So in any case, I think it's really cool work. And then this on the right was just showing that the heart rate exhibits less of a spike, just kind of using it as a proxy for perceived pain when babies were being held, which is really interesting. So environmental sound. So you can imagine the uterus acts as a buffer when the baby's in utero. But in the NICU, there are a lot of sounds. And so if you walk around the NICU, you will be more and more in tune to just how loud it is. So the American Academy of Pediatrics has recommended less than 45 decibels average as kind of the ambient sound that would be safe. So it's been shown time and time again that a lot of places exceed this limit, right? And so this was just one example of a study where they looked at both a NICU that was isolation, so just like separate rooms together, still really loud. So this is the 45 decibel recommended level that you stay below, right? This level 2 NICU, and they also had level 2 and level 3 NICUs in these two different NICU A and NICU B. NICU B was specifically designed to try to mitigate noise. So maybe it's a little bit better, but it's still, pretty far above the recommended level. So it's a problem that people are working to solve. But then the positive side of sound is mom's voice. And so when I was looking into papers for this talk, I felt bad because I don't want to leave dads out or leave, other caregivers out. But the reality is that the baby hears the mom's voice in utero for weeks and months, and that's what they're used to, right? So we've found that mom's voice, either recorded or live, it actually doesn't matter, or the data does not suggest that one is better than the other. Babies hearing mom's voice can decrease pain scores, and also maternal anxiety. That makes sense. Increase autonomic stability, feeding tolerance, weight gain, and like I mentioned, it's kind of specific to mom. Music. So a lot of studies have looked at different types of music. It's hard because most studies use different kinds of music, like take your pick. But in general, people have shown that it results in improved sleep, vital sign stability, decreased parental anxiety. And I think that that's a theme also, that providing a lot of these kind of positive sensory interventions you'll see in all the literature is it really does have an impact on parental anxiety. And I think it has to do with a feeling that they can do something, right? Because what a helpless feeling it is to have a baby in the NICU when, you would be doing everything for the baby at home. This is something that they feel like maybe they can participate in. So that's just my conjecture. But it is interesting that in most of these studies, parental anxiety seems to be improved. And so babies who listen to music tend to feed better. And then interestingly, you can see functional and structural brain changes associated with babies who've been exposed to music. So this is preterm control, preterm music, full term. So this is the a part of the brain called the amygdala. And so this is just showing that in preterm babies who listen to music, it doesn't get you all the way up to the volume of the full-term control, but it's improved from preterm control. And then they've also done studies that I don't have a graphic for, functional MRI, that show increased connectivity in music, with music in sensory regions and higher order cognitive functions. A lot of people have tried to look at the optimal NICU design. Single family rooms, open bays. People thought, in the open bay, they're exposed to more language, so maybe the language development would be better. Or, conversely, it's noisier, so maybe that would be worse. It depends on which study you look at, but some favor one or the other. And really, I don't have time to go through all of the papers, but just trust me on this. What they have found is that the important thing tends to be parental presence and involvement. So a single family room, if parents aren't there, is very isolating. The baby's not exposed to much positive sensory input. Then it results in worse outcomes than a baby in the open bay whose parents are there a lot. So that's kind of the gist, because there are so many confounding factors in these studies, but that has kind of been the salient feature of the findings. Scent. So we know that putting maternal breast milk onto little, this is an example of like a fabric cloth, and providing that as scent for the baby lowers pain scores and decreases fear response. Sight, so increase in light, even in small amounts, can lead to vital sign changes and disrupted sleep. And so a Cochrane review from 2016 did suggest that cycled light, so basically kind of cycling light on and off throughout the day to mimic night and day and kind of what they would be exposed to in utero, did have some indications, but trends toward most outcomes were positive with cycled light over near darkness or continuous bright light. And so you'll see a lot of NICUs, including ours, have these little blankets to try to decrease ambient light. So SENSE stands for Supporting and Enhancing NICU Sensory Experiences. And this is one of a multimodal sensory intervention, basically, that hopefully we are looking into adopting at our in our NICU. But it was developed by Bobby Pineda at USC and her colleagues, and it is very parent empowering. So I'll give you an example on the next slide of, so it basically takes into account touch, hearing, smell, seeing, and movement and body awareness, so kind of everything that I just talked about, and tells parents at each post-menstrual age week, so this is like for a 29-weeker, but because you can imagine different sensory interventions are appropriate for different gestational ages, but not for others. So think about how empowering this is. It tells them, okay, so protect your baby from direct or bright light, but then give at least 1 hour of positive touch a day. You can provide a hand hug. You can do kangaroo care, hold your baby in a blanket, read, sing, speak. So it kind of gives them direction on these evidence-based interventions to provide the positive sensory environment that these babies often lack in the NICU. And the studies so far, the actual data on the SENSE program is very positive, more to come. But it is suggested that these babies will have higher communication scores at 1 year, improved parent engagement, especially for at-risk populations, like for younger mothers and those living further away, improved parent confidence, and then better Hammersmith neonatal neurologic exam total score at term equivalent age, which Dr. Gupta talked about. So very, very exciting work. In these pictures, this is just an example of a hand hug, so that you can provide as a means of touch for those infants that are less stable. This is massage, not live action, obviously, so it looks like a hand hug, but and then this is kangaroo care with the baby on dad's chest. So that was just kind of a brief overview of all the things that people are looking at in the literature, and kind of the conclusions that have come about that, sensory experiences matter, both positive and negative in the NICU, and that it is something that we can do is think about the environment that we're providing, because these brains are undergoing so much development. It's such a vulnerable time for these developing brains. And suggestion that these multimodal interventions, such as the SENSE program, have potentially pretty powerful impacts for these babies. And they are still looking at kind of longer term outcomes when these kids get older with the sensory intervention, so stay tuned for more. But it's pretty exciting. That's all I got.